Well, hello, everyone, and welcome to our Data to Drive Decisions webinar. I'm glad to have all of you here with us today. Our topic today is the community dashboard that we have just released from the Center for Improving Value in Healthcare. It's information on cost and quality and access and utilization of healthcare services in Colorado. And I'm also joined by Doug McCarthy with Local First Foundation. I'll introduce Doug here in just a second, but he's going to be talking about how to actually put that data into practice. Before we go too far, I want to just talk about some housekeeping items. All of you are muted at this point in time, but we would love to hear from you. So please ask questions in the chat box at any point in time. Send us a chat. We'll have a formal Q&A at the end, but feel free to chat us questions throughout the meeting here. This webinar is being recorded, and we put all of the slides and a link to the recording on our events resources page on civic.org, and that will be up and live in the next couple of days. So everything you see here, you don't have to take notes. It'll all be available for you later. I'm Cari Frank. I'm the Vice President of Communication and Marketing here at Civic, and I am thrilled to be presenting with one of my favorite people in Colorado, Douglas McCarthy, Doug for short. He's with the Local First Foundation. He's a healthcare advocate with them. He's also an incredible researcher in the healthcare space, and he owns his own company, Issues Research, and he's also been on our board. He was most recently our board chair a couple of years ago. He's our past board chair, and he's been a wonderful asset to Civic and to the state of Colorado. So thrilled to have him with me. We will hear from Doug towards the end. What we're going to do today is talk about the community dashboard, what it is, why we develop it every year, initial results that we're seeing. I'll sample that journey kind of like a community that we think is interesting in the dashboard. And then we'll also, again, hear from Doug with Local First Foundation. He's going to give you a background about that work that they're doing and how they're using this data in conjunction with other data sources to advance the work that they're doing with healthcare initiatives. We'll have that time for Q&A towards the end, but again, feel free to chat into the chat box at any point in time. Just quickly about Civic, if you're joining us for the first time on this webinar, our mission is to equip partners and communities in Colorado and across the nation with resources, services, and unbiased data to improve health and healthcare. All of that is to make healthcare more equitable, and our vision is really that everyone has the same opportunity to access healthcare and healthcare services. We're nonprofit. Independent and objective. And I think that's very important, especially when we're talking about the data that we have and how we're using it and presenting it. So we serve a number of who we call change agents, and those are folks boots on the ground who are actually involved in healthcare, all with the consumer in the middle. And that's really the aim, is to make Colorado healthier. So we work with clinicians and hospitals, employer groups, government agencies, researchers, health plans, and nonprofit state agencies, all again to make the lives of Coloradans better. So we inform with the APCD data, both publicly and non-publicly, and the Colorado All-Payer Claims Database is a very robust database. We have over 1 billion claims as of 2022, which we're very excited to pass that billion claims mark. We've actually probably had a billion claims for a long time, but because we go back even beyond 2013, which is that billion number. We've been collecting claims since 2012, and those claims were retrospective from 2009. But we really think about the robust data being 2012 to most current right now. We have over 40 commercial payers, and plus Medicare and Medicaid. We get both Medicare fee-for-service and Advantage. And that represents the vast majority, over 70% of covered lives, which is over 5.5 million lives, unique lives in Colorado. That does include some of the self-insured employers as well. Trend information, again, it's very robust. So we go back to 2013, and that's the data that we're going to be showing you today. For some context, what's not in the co-APCD, we have federal programs such as the VA, the TRICARE folks, Indian Health Services. We can't at this point collect the federal program information, but we do have the majority of ERISA-based self-insured. We don't have the majority of ERISA-based self-insured. That's because of the Supreme Court ruling that says that we can't mandate, no state can mandate ERISA-based self-insured employers. They can voluntarily submit, and a lot of them are voluntarily submitting, but we also don't get the uninsured and self-pay claims, and some of the supplemental info is incomplete at this point in time. So again, then we turn that data into both public information and non-public information. You can always get custom data from us. We collect claims on a monthly basis, so the custom data can be much more timely. What we're going to talk about today goes through 2021 with the community dashboard, and that's because it takes a long time for us to develop this dashboard. We actually start work on it immediately after we release it. So it takes a full year of runway for us to pull this together. So we're very proud of it. Just some background information. It is actually part of the original legislation of the APCD that we produce population-based information on cost, quality, condition prevalence, and access. We've been producing some sort of the community dashboard since 2012. So with the same year that the APCD was launched, we started putting out information at the population health level, which just means across all of Colorado, for cost, quality, and all of these different measures. But we have made a ton of modifications since 2012. We've added new measures over time. We've pulled what was disparate reports into one, which you'll see today. We've created new visualizations and new Tableau, output. We've created more insights, and we also have really done a lot of work to make sure that all of this data that you're going to see is available in an Excel file. And actually it's multiple Excel files because it's a ton of information. We actually break it down into 44 different Excel files. So depending on what you are looking for, the data is very robust, and you can use it however you would like through those Excel files. So what's in the community dashboard? So we have a number of measures, which I'll talk to you about, but all of them are available from 2013 to 2021 for the most part. The only caveat is Medicare fee-for-service because of the timing that we get Medicare fee-for-service data. The Medicare claims only go through 2020 at this point in time, but we have all payers that are in the database, so you can look at the data by all the payers at once, or you can look at it by commercial only, Medicaid only, or Medicare Advantage, or Medicare fee-for-service only. It's all broken down by geography. So this is called the community dashboard because we want communities to be able to look at the information for their region and compare and contrast with other regions. We also have division of insurance regions, which is the way the division of insurance sets the rates for premiums in Colorado. So it's sortable by either of those, either at the county level or the division of insurance region level. And then we have demographics available in the Excel file. We don't have it in the interactive format, but age breakouts are available. So if you wanted to look at the pediatric population or over 65 only, and then we also have it broken down by sex, male, female, or other. So these are the measures that are sortable by all of those features that I just showed you. You can look at cost of care, which we provide by per person per year in the dashboard. A number of ways to look at it. We know that there are certain folks who want to see what's the all-in payment that might be going for the health plan and the patient. So we have that information available. We also have it just the health plan. What is the health plan paying per patient per year? And then just the patient only, which we'll talk about out-of-pocket costs as well. All of those categories are also broken down by inpatient per person per year, outpatient, professional, and pharmacy costs. And then quality measures, we've added some preventive measures as well as chronic condition management. So cancer screenings, are folks getting breast cancer screenings, cervical cancer screenings as guidelines suggests, as well as diabetes care, folks with diabetes getting their HbA1c testing. And then for mental health, we added in the last iteration a follow-up measure. So folks who wind up in the ED for mental health, nobody wants that to happen, right? And as a preventive measure going forward, you want to have anybody who does go to the ED for a mental health reason follow up with a primary care physician or a behavioral health specialist within either 7 days or 30 days. 7 days would be ideal, but we also have it available at 30 days also to give that perspective. And then in the utilization space, because cost isn't the only important thing, and Doug's going to talk about that a little bit too, we have a couple of measures to understand whether or not people are using their healthcare services. So healthy users and non-users. So those are people who have the eligibility files in the ABCD. So we get information no matter if you've used your insurance or not, so we can tell if you're a non-user. We don't want people to not use their insurance at all. We want you to be in the healthy user category if you are healthy, and because that indicates that you're going for preventive services and things that you should be using your health insurance for. So we have both of those measures, as well as some other preventive measure, both at the well child visit level and access to care. So those are similar measures, just a little bit different. All the methodology behind all of these measures is available on our website too. And then we have a couple of measures also that are utilization measures that folks don't want to be doing, don't want to have a bunch of people going to the ED for things that are preventable, but we also have all ED visits to give that perspective. And then we also have hospital visits, both preventable and readmissions as well. So we have readmissions at all readmissions, all 30-day readmissions, planned 30-day readmissions, and unplanned 30-day readmissions. So those are the measures. I'm actually going to pop out and show you the dashboard because I think seeing it is much more exciting than hearing me talk about it. Sorry, I'm getting a pop up here. So the dashboard lives on civic.org. And if you go to our Get Data tab right here at the top, and you go down to public data, the community dashboard is one of our focus areas. So this is one of our signature reports, and all of those are listed here, but that's where you would find it. We always want to put some considerations around here, and this just talks about what's in the ABCD and what's not as you're looking at this. We have a great infographic that's our cost of care infographic that I'm going to show you some of this information later, but we like to provide some insights and context around the data. And then when you scroll down, you will actually get the interactive report. I'm going to zoom in a little bit here for you guys, maybe a little bit more. So here is the dashboard. We have a definitions tab right here at the beginning, so that it will define all of the different measures. So this is the cost of care section. It'll tell you what's in there. Our cost of care is risk adjusted. We have non-risk adjusted in those Excel files I talked to you about. So if you're interested in the non-risk adjusted, that's there. Definitions for the breast cancer screenings and all the quality of care measures, as well as definitions for the utilization and access measures also. So those are always available in case you can't remember what one of the measures means or what the definition is. But one of the things I really love about this dashboard is the county or community level profile. And this gives you a snapshot. If you are in a particular county, you can say, let's look at, let's find one here. Let's use Alamosa because I'm going to use Alamosa later. You can select your county and see at a glance how you're doing across all of the different measures. So here you have Alamosa's cost broken down by the health plan and health and patient only in those inpatient, outpatient, professional, and pharmacy categories, health plan only, patient only. And what you have here are some arrows so that instantly you can say, okay, my county is higher because it's orange. It's worse than the statewide average for health plan and patient total. So a little bit higher. Alamosa is rural, so you can also see at a glance how does it compare to other rural communities, and it's actually a little lower than other rural communities. But you can see actually professional services, which is doctor visits, the payments directly to providers, a little bit lower than the statewide average and certainly lower than rural as well. So I like this as kind of a starting point. Some of the smaller rural facilities might have some NAs because that data might not be as robust and able to be presented. If there are too few encounters for that, we have to use suppression rules to make sure that we are in alignment with HIPAA regulations. So, but you have the ability right here at the beginning too to sort. So we were looking at commercial payers here, but if you wanted to look at all payers, since Medicare only goes through 2020, you could change those filters and look across all payers. Again, very robust way to look at your community all at once. And this is all downloadable too. So if you click on this button, you can actually PDF whatever you're looking at here. And then if you want to dig a little deeper, you can go to the specific cost measure or quality measures and utilization measures, and you can select whatever is most important to you. So if you wanted to look at health plan and patient total, we're still looking at Adams County, but you can go back to Alamosa. You get that snapshot right here in a bar graph of what is the Alamosa per person per year risk adjusted cost of care compared to statewide, urban and rural. And then you also have a map view as well. So Alamosa is down here, and then you can see the change from the previous years as well. So that is available in the map view, but it's also available if you switch this to from the current year value to trends over time. This is a new feature we added based on feedback that we got last year that's kind of hard to go one year at a time. So it'd be nice to have that roll up, which we provide here. So you can look at Alamosa, you can see, okay, 15% higher than in 2020, which is not surprising because of probably COVID. Folks are going back to the doctor and using healthcare services. So you can see trends over time, and you can see how that compares to the statewide, urban, and rural. We also have similar features on our quality of care. So if you're interested in just looking at diabetes care and seeing how that compares, or the current year value, you have very similar opportunity to look at the data that way at the map view. And similarly, the utilization and access measures are all here sortable as well. So I'm not going to go into all of these because I'm going to pop back to our slides. So I just wanted to give you a sense of where some of the data that I'm going to show you lives so that you can play with it on your own and look at the things that are interesting to you. So what we're finding, this all is in our infographic. Healthcare costs continue to rise across all payers, all payments per person per year. Again, this is that risk adjusted number that I was talking to you about. This is both health plan and patients combined. All of those payments from 2013 to 2020 in total went up 27% across all types of services, which of course we don't want healthcare costs to continue to rise, but unfortunately they are. But I think the interesting thing is as you dig deeper and deeper, you start to illuminate where those changes are happening. So provider payments are the highest per person per year, which actually we want those to be higher. Those again are those doctor visits. You want people to be using preventive care, but those are also anything that might have happened in a hospital setting or an outpatient setting. We provide that separately. It's not combined. So anytime you're looking at outpatient payments, is actually just looking at those facility payments. Hospital payments are just payments going to the hospital. So the provider services that might have happened in those settings are living separately. So those provider payments have gone up 27% over time. Outpatient payments have gone up 33%. Pharmacy payments were the highest increase. We saw over 97% increases in pharmacy payments from 2013 to 2020. There's a lot of work happening in Colorado around decreasing spending in prescription drugs. This is one of the reasons we see that there are huge jumps. And hospital payments have actually gone down, and that's been historically the case over time, ever since we've been producing this. We are seeing some hospital payments going down, which might be because a lot of things are shifting to outpatient setting. You're not having as many surgeries that need to be done in a hospital setting. A lot of that goes outside into the outpatient setting. Just a note, when we sum up these totals, you might, if you're a math person, you might have already summed up the totals here. The total is not going to equal this 7,200 because not everything falls in there, and not all Coloradans have both medical and pharmacy coverage. So it's a little bit of a tricky calculation to do, but don't expect those numbers to add up per se. So we also looked at just out-of-pocket costs, and those out-of-pocket costs are really important to be evaluating as people have more and more high deductible plans. We want to know, like, what is that impact on person's out-of-pocket costs. I have to give my our graphic designer on my team a shout out, because this guy cracks me up. He looks so sad with his bill and his broken arm and broken head. But the payments that people are having to pay out of pocket have really risen as well. I looked at commercial and Medicare fee-for-service and Medicare Advantage here, because a lot of Medicaid out-of-pocket costs are very low, if nothing. Commercial costs through 2020, from 2013 to 2020, rose 22%. So folks are paying on average $870 per person out of pocket. For Medicare, that jumped up 25% to $1,700 on average per person per year, and Medicare Advantage went up 51% to $1,400 per person per year. I also looked at the commercial data for 2021, and if you look at 2013 to 2021, it was an even bigger jump to $1,000, or a little over $1,000 per person per year for people with commercial insurance, and that's a 43% increase over 2021. So the story is not the same, though, for each county. Not all counties are increasing at the same rate or across the same sort of services. So I looked at the map and our underlying data and pulled out the two counties that are at the low end and the high end of the cost per person per year. This is, again, the risk adjusted health plan and patient. Gilpin is a small county just south of Broomfield, if you're not familiar with Colorado, a little more affluent probably than some of the other counties. They have a very low per person per year spending, $6,300, whereas Phillips County, which is a rural community up on the northeastern side of the state, again, both of these are very small counties. They have the highest in 2020 for per person per year spending. And as Doug is going to talk, I mean, you can't just say costs, rising costs or higher costs are necessarily a bad thing, because you want people to be getting access to care. Sometimes low costs could indicate people aren't going to the doctor when they need to. So it's not always a straightforward answer. We want, prices for services to be low, but we have other data that can help illuminate that. So I dug into Phillips County a little bit more, because these are some of the other things you can do with the dashboard. This is the second tab on the cost. You get actually a bar chart so that it shows you the county that you're selecting here, in this case, Phillips, and shows you by the service category what your spending is per person per year compared to the statewide, the urban, and the rural. And so what you see here for Phillips County, this inpatient is the orange. They have a much higher inpatient per person per year than statewide, urban, or rural. And they also have much higher outpatient per year, considerably higher, at least in this 2020 that I selected. So that's another level down that you can go, okay, what is perhaps driving some of these higher costs? So then once you have a peak there, you go, well, 2020 was a weird year. Maybe that's just abnormal. for Phillips County. But if you look at the trend graph, you can actually see costs tend to be a lot higher. This is the Phillips County here. It's always $10,000 or more over the years compared to the others. So higher costs consistently over time. That could be driven by the fact that Phillips County is very rural and probably has a higher Medicaid population or Medicare population in that county. I didn't have a chance to actually ring anybody in Phillips County and talk to them about this. I'm sure they would have some insights on that, but probably an older population that might need more healthcare services. So here's another level down that I just wanted to keep digging because we saw those outpatient services were really high. I thought, well, let's look at it by the different payer types in 2020 and see what might be driving it. Well, you look here at Medicare Advantage and look at this $18,000 per person per year. So that was huge numbers compared to what you see across the other payers for the outpatient setting. So again, it could be there's some folks, 2020 was a strange year. Maybe a lot of people needed COVID support in the outpatient setting. That would make a lot of sense. So again, you can look over trends over time and see if that's an anomaly or not. So this is just looking at Medicare Advantage trends over time. You see that there's been some other peaks even higher than 2020. Back in 2016, there was over $30,000 per person per year for the Medicare Advantage population. But a big dip in 2021. But it was fairly steady, kind of climbing from 2018, 2019. So that tends to be where a lot of the costs fall for them. Then you can look even more. I had so much fun digging into this. So you can look at their particular trends over time for all of the different service categories. And again, that outpatient was that spike that we saw. So here's that outpatient, and it's hard to see. It's these little bubbles in the green, the inpatient, outpatient here, professional, and pharmacy. So you can see that peak really did happen in the outpatient setting only, as opposed to not really seeing it for Medicare Advantage in any of the other years. So lots of stuff that you can dig into if you're a county and you're trying to figure out where to focus some of your energy. Outpatient settings is, a big, broad category. And I think the next level might be to investigate, what types of outpatient services might be driving those costs. We do have a cost of care analysis that goes deeper into outpatient services, and this is totally separate from our community dashboard. And this currently lives in our affordability dashboard. It's a cost of care tab in the affordability dashboard. It actually breaks down some of the top outpatient spending categories, filterable by payer type, by year, by division of insurance region. Unfortunately, this one is not available at this point in time at the county region. But it does show you what some of those outpatient service categories are. We see that surgery is primarily the biggest driver of outpatient services, as I was mentioning before. A lot of things are shifting from the inpatient to the outpatient setting for surgery. You can see that has kind of risen over time because that's highlighted here. But there are other things. ED visits fall under outpatient category, total prescriptions, and that's prescriptions that are being delivered in an outpatient setting. So it's physician administered. So lots of things that you can kind of dig into to understand what might fall into those outpatient services that might, bring up some other things that you want to dig into. And we can always provide more detailed information for anybody interested in looking at their community a little bit deeper. So we spend a lot of time so far on cost. That's not the only thing that is in the dashboard. I want to make sure to highlight some of the insights we're seeing across the other measures. This is the utilization measure set. We have those healthy users I mentioned before, which are people who are not using their insurance for things like preventive care. We want that number to be going down, not up, or we want healthy users to be going up, not down. So we actually saw a 15% decrease between 2013 and 2020 with people not using their insurance. That's not the way we want to trend. And similarly, non-users the people who aren't using their insurance at all, we want that to be going the opposite direction too. So it went up and we want that to be going down. But we did see some positive things in ED visits in general went down 10%. Potentially preventable, which we really don't want those things to be happening in the ED visit. We want that to happen in urgent care or doctor's offices. That went down 24%. Similarly, potentially preventable hospitalizations went down 45%. That's great news. And unplanned hospital readmissions went down almost 30%. So some good trends in things in terms of right place of service. But if you look at potentially preventable ED visits, I think during the pandemic, there was some concern and anecdotal data around folks not going to the ED at all during COVID times. And you don't want that to happen for things that could have been happening outside. So I just took a peek at the potentially preventable from 2020. It actually did go down quite a lot statewide. From 2020 or 2019 to 2020, we saw a 13% reduction in those potentially preventable. It kind of went up a little bit, 0.4% from 2020 to 2021, but still staying pretty low. So that's pretty good. And then if you look at Medicaid only, it's a little bit different chart. If you go back, so you see just kind of all over the place. But Medicaid has been trending down consistently over time. Saw a little bit of a blip in 2019, a little higher, but decreased to 26.8% in 2020 and went down even more in 2021, minus 4%. So a lot of good work, hopefully, to serve those Medicaid folks outside of the ED. That's great. And then in terms of quality of care and preventive care, we see some good trends, percent decrease in breast cancer screenings and cervical cancer screening, or increases, excuse me. We want to see increases in people getting breast cancer screening, cervical cancer screening that went up 5%. And even in, this actually goes through 2021 because it's not Medicare prescription dependent. So we're able to report at the all payer level through 2021. Diabetes is trending in the right direction, as well as those follow-up for mental health ED visits, both 7 days. 7 days went up 63%, which is huge. Even the 30 days went up 49%. The only decrease that we saw was access to care for children and adolescents went down from 2013, unfortunately. 5%, not a huge drop, but we are seeing that trending the wrong direction, whereas access to care for adults went up 3%. I added the actual percentage over here because when you just look at the trends, it doesn't always give you the information perhaps that you want to see. I highlighted these in orange because anything lower than 75%, I wanted to just note. So only 62% of the population are getting breast cancer screenings appropriately. So we definitely could do a better job there. Similarly, 55% are getting cervical cancer screenings. We have a lot of work to do there. And that 59% of folks are getting their ED visit follow-up within 7 days. We would like this to be higher because if someone's going to see their doctor within 7 days after an ED visit for mental health, their outcomes are probably going to be a lot better than if they waited that 30 days. For the visit. A little more digging. Again, here's our county friends in Alamosa. They are doing a great job. This is the follow-up for mental health for ED visits for 7 days. They have a high percentage, much higher than the statewide average. Statewide average is 60. They're up at 83% of folks who wind up in the ED for a mental health reason are getting that follow-up care. That could potentially be because of their high rates of telehealth for mental health. We also have an analysis that I'll show you here in just a second. But they've done a lot of work, it looks like, because they've been trending up and staying up high in this area in both 2020 and 2021. I did want to plug the telehealth. This is Alamosa down here, and they have had very high rates of per person telehealth use, especially in the mental health space. So I wanted to throw another plug out for another analysis that we have. There's a telehealth services analysis on our website as well, where if you wanted to look at your county and see how you're doing in terms of using telehealth services and for what, this new mental health focus tab that we just released not long ago gives more information at the specific mental health diagnosis level, so you can see what percentage of people are going for certain types of services. For Alamosa, it's post-traumatic stress disorder is the highest, and also what are the top services in general. So wanted to plug that. And another resource real quick before I turn it over to Doug. This is our health equity analysis, and it was our topic of discussion at our last webinar last month. It's on our website and on our YouTube channel if you missed it. But this actually pulls those some of the cost, utilization, and access measures that I just talked about in the community dashboard, and it marries it with social determinants of health. And so it's our health equity analysis where you can look even deeper than the county level. You can look at the census tract level, see what social factors might be driving some of the healthcare utilization, cost, and access measures that are in the community dashboard to address health equity issues that you may be facing in your community. This is just some of the things we found that those ED visits are definitely strongly related to all the social factors that we looked at, which are income, transportation, things like race, ethnicity. They were strongly related to adults not receiving preventive care. They are also did not have an impact on children and adolescents receiving preventive care, nor did the social factors have any impact on cost of healthcare services. And not a very strong relationship to social factors with that follow-up ED visit for mental health needs. So just wanted to highlight that really quickly, make sure folks are aware that that is a new report that's out there. If you're looking at health equity in your community, I wanted to make sure that you are aware that that exists. And with that, I am going to turn it over to my friend Doug and let him tell you more about how they're actually using this data in their community. Thanks for being here, Doug.
My pleasure. I really appreciate the chance to talk about what we're doing and just give you a flavor of why a community might want to use data that Cari has shown us. I've lived in Durango for about 20 years now. I work here. I am a health services researcher by training. And I'll tell you a little bit more about the work that we're doing through the Local First Foundation. Next slide. The Local First is an alliance of locally owned independent businesses that are values-based, and they come together to address what is known as the triple bottom line. So understanding the interrelationships of people, planet, and prosperity to create a more holistic view of well-being in the community. And a few years ago, we established a foundation to advance that work in the community, which is a 501c3. Slide. Some of the work that we do on the foundation side is really address at the social determinants of some of those things that Cari was talking about in the equity analysis, making sure that there is a living wage and basic needs such as affordable housing. Several businesses have committed to giving back 1% of their profits each year to support that work, which is really very heartwarming. But what we heard from our businesses back in 2019 was that one of their biggest pain points was healthcare costs. It was becoming increasingly difficult for them to offer benefits to their employees, or they just simply couldn't offer benefits because of the cost. So they asked us to address that issue. And very fortunately, we were able to partner with the Peak Health Alliance, which started that same kind of work in Summit County. And we were able to bring together that model to the Southwest Colorado, to the 5 counties here, including La Plata County, to help put the community at the center of designing and finding a health insurance carrier that would be a more affordable option for both businesses and individuals. But we also understood with that healthcare is multifaceted, and if we were going to address costs, we had to look more holistically. So we created an accountability initiative. And you may say, well, who's accountable to who? We're accountable to each other as a community to try to support a shared accountability for not only costs, but access, quality, equity, and outcomes. To do that, we have partnered with the League of Women Voters here, and we are creating a new entity called the La Plata Healthcare Improvement Coalition, which will take that work beyond affordability. And then finally, just trying to address what we're calling healthcare literacy. How do you actually use your benefits? So one of the product innovations was we offered first dollar coverage for mental health, making sure people know that they have that coverage. Next slide. So in our healthcare accountability work, we wanted to understand the full scope of data that we could potentially include in a community dashboard to track our work. So we were very thrilled that Civic has tools and data that are a big part of what we're thinking will be a part of this dashboard, and you can see some of the other sources of information that I won't talk about, but that we're also considering to round that out. So a big anchor of that is the community dashboard that Cari just presented. And we actually started presenting that to our community several years ago before this accountability dashboard work began. And one of the things that was very helpful for physicians, for example, was to see the bigger picture that of the community that they work in. They see their practice and they understand what happens and what they're trying to do, but what is the impact on the total community? And one insight was that preventive cancer screenings were much lower on a community-wide basis than they would have guessed, and that was a concern. And that led to some of the interest that we are now placing on healthcare literacy to make sure people know that they get these services for free. The healthcare equity analysis is another part of that, and then other reports that Civic produces that we're also very excited about including in this kind of a dashboard. Next slide. In addition to the community level, we want to empower people to make more informed decisions, whether those are businesses or individuals. And so we hope to promote Civic's Shop for Care tool, which provides prices for shoppable services. You can't shop for all services, but some of them you can. And then comparing commercial or private insurance payments to Medicare and creating a standardized way to talk about price. And that's been very important, that the work that Peak Health Alliance has done in talking to hospitals in the region about how we can try to work together to have a more affordable health insurance offering with more affordable prices. Next slide. So I'm just going to show you one example of how we've tried to bring some of this data together already. We don't have our dashboard fully complete. This is a work in progress. But one of the things that we were excited to do was to look at marrying the equity analysis and the community dashboard that Cari just presented, and that's shown in blue on the right. And so we were so excited to see that now we can move left here and see that same data that we presented to our community on a census tract basis, and really understanding the wide variations that are existing just within our county on some of those measures that would be hidden in that average. And then looking to see where there are correlations, and you can see both in the leftmost and the rightmost census tracts are both higher need areas of our county where there is a stronger correlation between those social determinants on the top and those healthcare measures on the bottom. So that helps us in our work to understand, okay, we're going to look for synergy between our social determinants work and our healthcare work. But interestingly enough, you'll see in the fourth census tract from the left, there isn't a real strong correlation there, and that may just reflect the heterogeneity of that particular census tract in the western part of our county. Next slide. We were also really interested to try to understand those correlations. So Cari presented to you earlier what she saw at the statewide level, which is shown on the right. What we saw in our own county was a little bit different. So there were still those correlations at the bottom with emergency department use, for example, that we could impact. They weren't as strong in our county. Where we saw a stronger correlation in our county was in quality of care, and specifically here, follow-up after mental health visits. And that's really important to us because we have heard through interviews that we've been conducting and just the work that we do in the community that mental health is a big issue for people. And so now we know this is an area that actually makes a lot of sense to tackle both from a social determinants and a health care quality perspective. And then in the upper right, you'll see race, ethnicity, and language, REL. That was also much more highly correlated in our county. We have 2 tribes here, and so that's an area we want to explore to understand the role that that's playing in our county as well. So that is just a very high-level overview. I want to thank all the funders that have made this work possible. And if you're thinking of doing community work, being very broad-based and understanding how you can engage as many stakeholders as possible really helps not just for getting funding, but for engaging the community and understanding the work and then trying to find actions that we can take together to improve. Thanks.
Well, thank you so much, Doug. We're going to look to the chat, and if you guys have any questions for either myself or Doug, feel free to put those in the chat box. I don't think I've seen any yet, so we'll take a moment. I guess I have a question for you, Doug, that maybe as we are waiting for folks to have questions, what would you suggest to folks who maybe don't have a, analytic background? I think, your community is so lucky to have you that you kind of understand these data sources and you thought like, oh, okay, these are the places to look. Do you have any suggestions for folks on like just where to start? Like, I think it can be overwhelming.
Yeah, and I think the answer to that really varies depending on your audience. And so we do understand that we don't want to overwhelm people with a lot of data that's just like a fire hose coming at them, and that might actually discourage them from wanting to take action and be engaged. And so we do want to have a funnel that we use to decide how we're going to, which data we're going to actually track over time, which is more important, which is less important, and to come up with some leading indicators that would kind of cross over. In our work, we're dividing into work groups that have an interest in specific areas, and so our thought is that we'll be tailoring the data to each of those interests that the community might have. And so, yes, I think start where you can. I think the community dashboard is an excellent place to start, along with the county health rankings, to understand where you have some gaps, and then where you might look for some early wins to try to address those.
Yeah, that's great. I think that people, in my experience in community alliances and stuff, I think sometimes you try to bite off a little too much, and then there's frustration because there's not enough movement. So I think zeroing in, like you said, on what are the biggest drivers that I can tackle now and see some early wins, and then we can add things as we go on. Looks like I have a question from Dave. Are we considering more robust quality measures? Yes, the answer is absolutely yes. We add, usually we add measures every year. This year was, we just updated everything. We didn't add any new measures, but we have a big project over the next year that we're going to be developing, I think over 55 different quality measures in conjunction with Medicaid to support some of the work that they're doing, but it actually allow us to build those measures within the APCD. And then we'll be able to say, okay, which ones of these make sense to produce in the community dashboard. So we will be able to, probably won't be in the next year's iteration. It's going to take us a full year to do the development because it's a long process for us to do that and build it within the database, but probably in following years, we'll be able to add new quality measures. Dave, if there are few that you are particularly interested in, we always want folks to let us know which ones would be beneficial to you. So feel free to, anybody can email me. This is info@civic.org, but I'm cfrank@civic.org. So if you guys have suggestions on new measures to add for the next iteration, we're actually, as I mentioned, we start planning the next time we're doing it immediately. So we're starting that process now. So I'm gathering suggestions for alterations in the next iteration. I know Doug had a suggestion for putting utilization information side by side with the cost. So, not just what is the inpatient cost, but what is the inpatient utilization per person per year also, so that you could compare, is it because we have more people in the inpatient setting, or is it because inpatient costs for us are higher? So I think that is a great suggestion that we'll take back to the team and check into feasibility for that. So any other thoughts and suggestions, feel free to, here, I'll put my information into the chat box, and feel free to send me an email.
I do want to commend Civic for being responsive. I think I was one of the people asking for the trend analysis, and so it's so great to see that added as well.
Yeah, we look at this stuff so much that it sometimes it's hard to take a step back and go, okay, what would be valuable? And we can't do that ourselves. We want to really hear from people using it. So as you guys start using it, hopefully you've gotten some great ideas from Doug and the work that he's doing. Feel free to let us know if you have additional suggestions. Let's see. So I don't have any other questions in the chat. So it looks like I think we must be good to go, and we can give people back 10 more minutes in their day, which I know everyone will really enjoy. Doug, thank you so much for being here with us. We really appreciate you sharing. It's one thing to just show the data. It's actually amazing to hear how people are using it. So that's been so fun to hear, and we can't wait to continue to track the progress from Local First and see how you guys are doing great work down there in your area. So, and thanks for all of your support for Civic in general and as a board member as well. So have a great day, everybody. We appreciate you joining us today, and we will see you next time. Thanks so much. Bye-bye.